I was given the task of presenting a case of a transplant-eligible patient with newly diagnosed multiple myeloma. Would you recommend transplant? And if so, what induction regimen? These are my disclosures. So here's the case. A 45-year-old male, history of obesity, type 2 diabetes, so he's American, diet controlled, develops back pain after moving furniture. When the back pain doesn't relent after 3 weeks, he sees his primary care doctor who advises NSAID use. There's minimal relief after taking 800 milligrams of ibuprofen 3 times a day. He then sees his primary care doctor again, and a plain film of the spine is ordered. So multiple lytic lesions are seen. He's then referred to an oncologist. A bone marrow biopsy is performed. In case you're interested, you can get the details of his medical history in your little handouts. I'll just move forward. So the skeletal survey shows multiple lytic lesions distributed throughout the spine, cranium, pelvis, right proximal femur. The bone marrow shows 86% plasmacytosis, kappa light chain restricted. He has normal karyotype, and his FISH shows a deletion 13 in 2 out of 20 cells. The diagnostic testing essentially reveals a mild anemia, mild renal insufficiency. You can note that the beta-2 microglobulin is 3.8 and the albumin is 3.6. On serum protein electrophoresis, he has a monoclonal spike of 3.2 grams per deciliter. His total IgG level is 4,300 with immunoporesis. And his 24-hour urine electrophoresis has approximately 2 grams per day of kappa free light chain. And his free light chain analysis shows a highly elevated kappa free light chain with an abnormal ratio. So the summary is a 45-year-old male, history of hyperglycemia, newly diagnosed Salmonella stage 3A, and that's based on the extensive lytic disease, ISS stage 2, IgG kappa multiple myeloma, mild renal insufficiency. So is a stem cell transplant recommended? So one could argue that a stem cell transplant has an overall survival benefit, but my caveat to you is that data is old, and now we're looking at like 20 years old. And we also know that a stem cell transplant deepens the treatment response. But does a deeper response post-transplant lead to a longer overall survival? And what do you do about a patient who's in complete remission prior to transplant? That happens all the time now with novel therapy. So I won't belabor this slide other than to tell you that the studies that showed that transplant led to survival over conventional chemotherapy, these are all sort of set in stone, but they use therapies that are out of date, mostly cytotoxic regimens. We also know that the timing of a transplant doesn't really matter based on this study by Furman. The caveat to this is looking at conventional induction regimens, no novel therapies here. So does a consolidation with a transplant actually improve outcomes that you're looking for, mainly being overall survival? So there was an analysis by the Spanish group looking at responses to induction therapy relating to responses after a transplant. And we see that the results are not that surprising. The better you do with induction, the higher your chance of achieving a complete remission post-transplant. So there definitely is a consolidation effect there. And the depth of response does correlate with both event-free survival and overall survival. Again, not surprising. Obtaining a remission leads to better outcomes. If you obtain your remission before the transplant or after the transplant, doesn't really matter. Upgraders do better. So just because you didn't get into remission with induction therapy doesn't mean that your remission doesn't count just as well post-transplant. Upgraders do better than if you had never gone through the transplant at all. However, looking at some older trials and studies, we can see that the initial response to induction with conventional chemotherapy doesn't really impact transplant benefit. And there's a number of trials looking at traditional chemotherapies like CVAMP, others like VAD. Alexanian looked at a group of patients with myeloma that were resistant to VAD or high-dose dexamethasone and showed that the transplant still had benefit. So the message that I get from this is even if your patient has rip-roaring disease, not responsive to conventional chemotherapy, a transplant is still useful. So these are some graphs basically saying that same point. Well, is that statement that I just said still true in the era of the novel therapies? So there's this great retrospective study out of the Mayo Clinic looking at 286 patients and looking at the progression-free survival from day 0 of transplantation. And they divide the patients into 3 groups: those who achieved a plateau in response with induction, those who turned out to be refractory to induction, and the worst group, which were those that got a response and lost it quickly. So they're divided into the plateau, refractory, and relapse group. The modern therapies that were used were mostly thalidomide dexamethasone, but there were some lenalidomide dexamethasone in there. And we can see that the progression-free survival is best for plateau, not so great for refractory, and really bad for relapse. What about overall survival? Follows the same pattern. Patients who are completely refractory or even worse, relapse while on novel therapies, at least Thaldex and lenalidomide dex, have a very short overall survival, which is contrary to the statement that response to conventional chemotherapy makes no difference. This changes with the novel agents. And when they did an analysis of the factors that are important for overall survival after transplant with novel therapies, really what matters is your response to the induction therapy and also the percentage of cells that are actively proliferating, known as a labeling index. Cytogenetics were also important. So I went back and I tried to look at studies that compared novel agents to conventional chemotherapy followed by an autologous stem cell transplant. And the data is somewhat confusing, although some trends do emerge. If we look at the HOVON 50 study, for instance, which was TAD versus VAD, and the V for that VAD is for vincristine, we can see that the overall survival was better for the TAD group. For the IFM study, the overall survival was quite similar, suggesting that the transplant may overcome any sort of resistance to conventional chemotherapy. On the Jemima study, VTD versus TD, we can see that overall survival is also quite similar. And this is really what we have to go on right now. So the million-dollar question is, do you still need a transplant if you get a complete remission with induction therapy? Nowadays, with modern therapy, a very high proportion of patients do, in fact, achieve a complete response. And what we can see here from this retrospective study done by Wang, people who get a CR with chemo alone have equivalent outcomes to people who get a transplant and achieve a CR within 1 year. And this is quite striking. But it seems that a CR is a CR is a CR, whether you get it with induction or with transplant. There is some corollaries to that as well. The other question that comes up is, do you need a transplant if you can continue induction therapy instead? And I take this data from our own homegrown study of BIRD, where a combination of clarithromycin, lenalidomide, and dexamethasone was either given continuously or stopped at time of transplant, at which point patients were observed instead. And here we see that the results are equivalent for event-free survival. Progression-free survival is always also equivalent. And we have 5 or 6 year follow-up at this point, showing that the curves actually don't separate all that much. So the conclusions are, combinations of novel agents lead to deeper responses pre-transplant. That shouldn't be a surprise. Deeper responses pre-transplant translate to better responses post-transplant. Also not a surprise. So I view that transplant is a supplement to induction and not a substitute. And transplant is a tool to achieve higher CR rates and prolong progression-free survival. The lack of difference in overall survival across multiple studies is a reflection that we have many agents available now to salvage our patients. Also, the achievement of a CR prior to transplant gives an equal outcome to CR post-transplant. However, we need to do minimal residual disease detection and perhaps look at this in a prospective manner to actually make a conclusion definitively about this. So, next part of my task is, what induction therapy should be used? What's more important, the choice of agent for induction or the response attained in induction? You should be able to get the answer from what I've presented a couple of minutes ago. So what I want to remind the audience is to see the forest for the trees. You have here 2 lobsters engaged in a death match. One is clearly handicapped because he has a rubber band around his claw. And both of them are probably going to wind up in some boiling water. So what's the point? There is data comparing multiple induction regimens using 3 drugs or so: Cybor-D, bortezomib cyclophosphamide, dexamethasone, bortezomib, dexamethasone, thalidomide, BIRD, bortezomib, lenalidomide, dexamethasone. And the point I get across from this is that the results are very similar for these induction regimens. And I would venture to say, I don't think I'm going out on a limb here, is that you could pick any 3 drugs you want, and you would probably get an okay induction for what you're going for, which is a deep response.